Hello everyone, nice to meet you once again. So just a small recap of what has happened yesterday. I'll just try to and I want to tell you that all of you have been unmuted, so please listen to the class carefully. I'm going to ask you a few questions and then you have to answer them back. Okay? I'll just note down who's answering and who's not. So be present and listen to what all I'm talking. Right, so the esophagus, I told you, is a hollow muscular tube that starts from the oropharynx and extends into the fundus of the stomach, right? So here we have three parts, that is the cervical part, the thoracic part, and the abdominal part. And then we spoke about the histology of the esophagus, that is the upper two-thirds of the esophagus is different from the lower one-third in terms of the muscle layer, that is the inner circular muscle layer, which is striated in the upper two-thirds, and the smooth muscle layer in the lower one-third. And then the esophagus is lined by the stratified squamous epithelium. It doesn't have a serosal layer. The submucosa is having mucosal glands. This is about the histology of the esophagus. And then we spoke about the constrictions, that is anatomical constrictions and the physiological constrictions. The anatomical constrictions are number one at the cricopharyngeus level, that's C5, C6, and the T4, T5 sternal angle, that is a tracheal bifurcation. Then at the level of the lower esophageal sphincter at approximately around T10, right? And then we spoke about the physiological constriction, that is upper esophageal sphincter that prevents the air, and then the lower esophageal sphincter that prevents the food and the acid back into the esophagus when we eat. So this is about the anatomical constrictions and physiological constriction. Then we spoke about the congenital lesions that can occur by the 7th week. The trachea and the esophagus are separated. The trachea runs in front of the esophagus. And then if they are not separated, that will form tracheoesophageal fistula. It is always associated with atresia or thin non-canalized tube formation. Then there can be outpouchings at the level of the muscular weaknesses, that is the Zenker diverticulum and the traction diverticulum. And then we also spoke about the hiatus and the muscular disorders. The hiatus, one of the three types: the sliding, the paraesophageal, and the pleuroperitoneal hiatus, right? And then we spoke about numerous esophagitis, that is the gastroesophageal reflux disease causing the Barrett's esophagus. Then the Barrett's esophagus, the pre-malignant condition wherein we can see the intestinal metaplasia, that is the presence of the goblet cells that is replacing the stratified squamous epithelium. So this is about the Barrett's esophagus, right? So again, I have already told you about the various types of esophagitis, which can be infectious, chemical, and non-infectious, right? So these are about the infectious. Then just to tell you about the achalasia cardia, which is present at the lower esophageal sphincter, wherein there is increased ileus tone, and then there is no backflow or no entry of the food into the stomach. So this is about the achalasia, right? And then we spoke about the various types of malignancies that can occur: the squamous cell carcinoma, the adenocarcinoma, more common than other types of malignancies. The adenocarcinoma is predisposed by Barrett's esophagus and dysplasia, and adenocarcinoma in situ, and the extensive adenocarcinoma. So this is all we have about the esophagus. And one more important thing we have to know about in the esophagus, you have to remember about the varices that can occur because of the portosystemic anastomosis, about the azygous vein and the left gastric vein, which form the esophagus, which drain the esophagus, and then they get inserted into the portal vein, and they drain the liver. So whenever there is a liver abnormality, you can see that there is a backflow, formation of collaterals, and formation of esophageal varices. So any liver pathology may lead to varices formation, and then the rupture, there can be hematosis, right? So a few questions to look over. I want everybody to be present and answer these questions, right? So a 28-year-old woman complains of a burning sensation in the chest for past 3 months. The burning typically begins in the upper stomach and travels along the neck. Symptoms worsen when she lies down or go to sleep. She recently quit smoking. Her temperature, blood pressure, pulse, respiration rate seems to be normal. So the physical examination is unremarkable. The most important next step is so there is burning sensation, okay, and then the symptoms worse when she is lying down to sleep. All other things are fine except that she is a smoker and then she has recently quit smoking. So these are your option A, ambulatory esophageal pH testing, order upper gastrointestinal variant radiograph, recommend elevation of head of bed and avoidance of food before bedtime, schedule an upper endoscopy. Yes, guys, what do you think is the answer? Yes, come on, I should hear. At least say no if you do not know the answer. Yes, anyone? Okay, fine. So recommend elevation of the head of the bed and avoidance of food before the bedtime. This is the primary thing. Before you give a medication or before you give any other advice or investigation, the proper thing is to channelize the lifestyle of the patient. So that's the reason why you try to recommend elevation of the head of the bed and avoidance of food. Okay. Then next question, 45-year-old man came to hospital because of heartburn for 3 months. He tells you that he has a burning sensation. The same thing, he travels up to the neck. He drinks 2 to 3 cups of a tea, has a glass of wine after dinner, has a piece of chocolate candy. You recommend that you elevate the head of bed, avoid eating before food, can avoid all alcohol, tobacco, chocolate, and schedule a follow-up visit. He comes back after 2 months to you and says that his symptoms are unchanged. The most appropriate management is next. So what do you think? What do you think is the patient suffering from? I told you the food is getting back into the esophagus. So what is the condition? Yes? We spoke about the reflex, right? What is the condition we're talking about? Is anyone? It is gastroesophageal reflux disease, right? So for that, I'll not ask for anything, any suggestion other than giving the medication, because I already know that it is a gastroesophageal reflux disease, which in spite of avoidance of all the things like alcohol and caffeine, which will increase the esophageal reflux, I just know the diagnosis, so I just put him to the ranitidine directly. And the third one, that is 64-year-old man complains of burning retrosternal pain and heartburn that is brought about by bending over and wearing a tight belt. He gets symptomatic relief from the over-counter antacids. The problem has been present for many, many years. This is the clue, and seems to be progressing. Which of the following is the most appropriate next step in management? The same thing, he is suffering from gastroesophageal reflux disease. You know that the problem, even by using antacids, it has not been subsided and just progressing through many years. So what do you expect? Long-term gastroesophageal reflux disease may cause Barrett's esophagus, that is intestinal metaplasia of the lower end or the distal esophagus. So we have to do an endoscopy and a biopsy. That's your answer, right? So the next one. 45-year-old man who is admitted to the hospital for alcohol detoxification developed bloody anesis. Patient has a history of alcoholism and hepatitis C. Vital signs, temperature is normal, and the blood pressure systolic is about 180, the pulse is 122, respirations are 9 per minute. The patient is oriented and answers normally. Physical examination reveals that he is jaundice, that means there is some liver abnormality, mild lethargic state. You also have a clue that it's hepatitis and alcoholism. And then he has ascites, caput mellicae, and lower extremity edema. The urgent clinical issue that should be addressed is, so what do you expect when there is a liver pathology? We already know that we're talking about something. There is a backflow of the blood, the portal and the systemic veins get, there is a connection there, and there is formation of collaterals. So I just now told about it. So what do you think, guys? Anyone? I just told you. Before I started the class, I gave you a recap of what happened yesterday. I just told you it is a portal hypertension with formation of collaterals. Then the resultant is what? I'm not sure if anybody is watching or listening to me. Yeah, what is it? It is a variceal hemorrhage, right? See, why we are not talking about cirrhosis or something is that the most urgent thing that has to be addressed is the bleed that is caused by the collaterals, okay, because of the rupture of the varices. So that is the most urgent thing. The patient may collapse because of loss of blood. So next question, 45-year-old man complains of increasing difficulty in swallowing over the past 3 years, reports feeling of pressure in his chest occurring 2 to 3 seconds after swallowing solids. He also experiences regurgitation of undigested food eaten previously. A radiograph taken shows a distant esophageal body with smooth tapering at lower esophageal sphincter, the acute. A radiograph shows a distant esophageal body. So the lower esophagus has got distended with the smooth tapering at the lower esophageal sphincter. The manometry shows the absence of esophageal peristalsis. So there is a triad we're talking about, that is increased LES tone, failure to relax of LES, and then aperistalsis. That is the triad with which we are talking about. So with swallowing and lower esophageal sphincter that fails to relax. What is the most likely diagnosis? Come on, this you have to say. I've already told that it's a triad. The triad is increased LES tone and
Achalasia.
yes, achalasia. Excellent. Very good. So that is achalasia. So come on, answer the following. What are the causes of hematemesis? We spoke about a lot of esophageal conditions, right, yesterday. So at least tell me 2 conditions which can cause hematemesis. Yes, guys, I told you there is a variceal rupture that can cause hematemesis. The gastroesophageal reflux disease, if it is present for a long time, it can cause hematemesis. Then if there is a carcinoma or a malignancy of esophagus, that can cause a hematemesis, right? So there are many causes. If there is a tear, we talked about the malarious and the Borhives, if there are tears in the mucosa of the distal end of the esophagus, that can cause hematemesis. So you just have to know that itis, the inflammation present for a long time, can cause rupture or that can lead to hematemesis. The variceal formation, the malignancies, the masses, the foreign body impacture, all this can cause hematemesis. The next question, Barrett's esophagus leads to development of Barrett's esophagus leads to development of. What is Barrett's? Barrett's, I told you, is intestinal metaplasia of the distal end of the esophageal mucosa. The normal esophageal mucosa is stratified squamous epithelium that is replaced by the intestinal epithelium. How can you say it is intestinal? It consists of columnar epithelium and the goblet cells. Right? So then the Barrett's esophagus may transform to dysplasia and then the mucosal adenocarcinoma in situ, and then it can cause extensive adenocarcinoma. Right? Most important site for formation of carcinoma esophagus is, we said there are upper 1/3, middle and upper, middle and the lower segments. What do you think is the most common cause? Yesterday I gave you a picture depicting the esophagus middle third consisting of 50% of the carcinomas which occur there, right? And what is Plummer-Vincent syndrome? The Plummer-Vincent syndrome is related to the iron deficiency anemia with esophageal webs, and then there can be oral and mucosal lesions. So this is about the Plummer-Vincent syndrome, already also called as the Patterson-Kelly syndrome. So today I am going to speak about this. What? Yeah. Today I'm going to speak about the stomach. Just the overview of what I'm going to talk to you about today, the normal structure, inflammatory conditions like gastritis, peptic ulcer. Okay. So here we go. What are the parts of the stomach? There is cardia, fundus, body, and the pylorus, right? So there are 4 parts. The cardia consists of what? Histologically, it consists of mucus secreting cells. That's a foveolar epithelium with the short tubular glands, right? So this is a cardia, is nothing but the esophageal gastric junction is called the cardia. There is no extra place for the cardia like the fundus in the body. You know, you have seen there's a lot of place for the fundus in the body. You know, there's a lesser curvature and the greater curvature. Now, what does the fundus in the body contain? They contain the parietal cells, also known as oxyntic cells, the chief cells, also known as zymosin cells, and the endocrine cells. So these are the cells which are present here, right? I told you the foveolar cells will secrete the mucin. The parietal or oxyntic cells will secrete the HCl, the acid, and also the intrinsic factor. The chief cells or the zymosin cells are necessary to give you the pepsinogen enzymes, which are the proteolytic enzymes, which are necessary for the protein digestion, right? So this is the chief cells, and these are the parietal cells, also known as the oxyntic cells. Now that we have seen about the cardia, the fundus in the body, both are having the same types of cells. And then the pylorus has G cells and also the same mucus secreting cells. So these are the mucus cells in the pylorus. There are long tubular glands, contradictory to the short tubular glands in the cardiac mucosa. And then the pylorus travels into the duodenum. So we are seeing the 4 parts here, the cells. What are the cells secrete? The parietal cells secrete the intrinsic factor and the acid. The chief cells secrete the pepsinogen. Then here we talked about the pyloric mucosa, wherein it is secreting mucus, it is having mucus cells and also the G cells. See, the G cells are intrachromaffin-like cells which will help in turn to give a signal to the parietal cells to secrete the acid, right? So the G cells will act as a stimulus for the parietal cells. This is about the histology and the parts of the stomach. So once we talk about the histology and the parts of the stomach, we'll speak about something called as the phases of acid secretion. The phases of acid secretion are the cephalic phase, the gastric phase, and the intestinal phase. The cephalic phase is the one where I smell something which I like, and then my sinus gives a signal. That is the cephalic phase, wherein there itself, before you start eating itself, there will be secretion of the acid into the stomach. That is about the cephalic phase. In the gastric phase, you know, after eating, you get the food digested in your stomach. That is the gastric phase. Then the intestinal phase, right? So before we go into the congenital lesion of the stomach, I want you to tell me what happens if the person is having any kind of a gastric problem. If a person is having a gastric problem, what does a patient complain of? You have a stomach pain ever, right? So you have all your guts are fine till date. Did you ever have a stomach problem? So tell me what chief complaint the patient comes with when you have a stomach problem involved.
Burning sensation.
Yeah, burning sensation, very good. Then
chest. In very severe conditions, there is a chest pain.
Awesome, awesome, very good. Next. Usually it's epigastric pain which we experience, right? Have you ever eaten a bit of spicy food, then you have an epigastric pain? So epigastric pain, heartburn, then there can be hematemesis when there is rupture of some thing in the stomach. Then there can be peptic ulcer formation because of increased acid secretion. Then what does the patient complain of? He can complain of melena. What is melena? By the acid, the hemoglobin transformed itself into the acid hematin, right? Because of the action of the acid. So what happens is that there will be dark colored tarry stools. That is a sign of upper GI bleed, right? So a person can come with chest pain, epigastric pain, vomiting. He can come with lot of ulcerations, hematemesis, melena, right? So all these things can occur when a person comes to you. Okay. Now after that, we are going to see very a simple thing that is just one congenital lesion, unlike the esophagus. Esophagus, you've seen a lot of congenital lesions that can be atresia, duplication, agenesis, then there can be tracheoesophageal fistula, right? So here we have just one condition you have to remember regarding the stomach, that is a congenital pyloric stenosis. So what is pyloric stenosis? See, stenosis means narrowing, right? So why does it narrow? There should be some muscle which has got hypertrophied or something from the outside pressing it, right? So we'll see what it is. So there is concentric enlargement of the pyloric sphincter, narrowing of the canal, and then that is obstructing the gastric outlet and is associated with the projectile vomiting. I told you there are four parts of the stomach: the cardia, fundus, body, and the pylorus. So where is the pylorus? Down to the attachment of the duodenum. So that pylorus, if it gets stenosed, what happens? The food content which is digested in the stomach, it can't go into the intestine. So what happens? Obviously there will be vomiting. So I am saying this is congenital. So the baby usually complains of vomiting. They can't get any milk digested. So here you can see the pathogenesis. It usually have a genetic basis. There's a familial tendency, and it is usually seen associated with the Turner syndrome, trisomy 18, and esophageal atresia. See, I told you atresia is thin non-catalyzed tube that is also associated with tracheoesophageal fistula. So it's the same way this is associated with congenital pyloric stenosis as well. So coming to the next one, that is embryopathy associated with rubella infection and maternal intake of thalidomide have also been associated with congenital stenosis. So an infection or a teratogenic agent can cause some deformity while formation of the gut, so that can cause congenital pyloric stenosis. So gross examination of the stomach, if we do, what we'll find, there is concentric pyloric enlargement and narrowing of the pyloric canal, right? Then the only consistent microscopic abnormality is hypertrophy of the circular muscle coat. In the stomach, we have seen epithelium, the mucosa, that is a mucosa, submucosa, muscularis, and serosa. The serosa is absent in esophagus. Here the serosa is present, right? In the esophagus, you have only the adventitia. Here you are having the serosal layer, right? Remember that. So here what we see is that there is large muscularis here, which is completely consisting the pyloric lumen. So we find that the lumen is very thin, and then there is enlarged pylorus, right? So what are the clinical features? Vomiting, obviously. Then loss of hydrochloric acid, because you're trying to secrete the acid to digest the food and to just make it go into the intestine, but you're not able to. Then a palpable pyrolic lesion. So the food and the pylorus, if it gets enlarged in the infant, you can see there's just something that we can just palpate, right? And then visible peristalsis. There is an obstruction here. I want something to go in. What I'll do, I'll push it and push it continuously, right? So what will happen? You can see this kind of a movement, just the trying of the peristaltic movement to make the propels the food into the intestine can be seen. So this is about the visible peristalsis. So usually we can see, even in the infants who are healthy, we can see right to left peristalsis. But here, the peristalsis is left to right. That you have to remember. Okay, the surgical incision is the only curative thing. Okay, then I told you the nerve muscle coordination is very necessary for the movement of the food, for the peristalsis, the vagus, everything. So after knowing about the congenital pyloric stenosis, could you just tell me if there can be an acquired pyloric stenosis as well? Can we acquire? Can I acquire pyloric stenosis as well? See, until now, I spoke about congenital pyloric stenosis, wherein there is hypertrophic concentric enlargement of the pylorus with narrowing of the lumen, right? So I'm asking you, can I now, with this age, have an acquired pyloric stenosis? In the esophagus, see, any inflammation can cause fibrosis, right? So only muscular enlargement will cause stenosis, or even the fibrosis can cause stenosis. Yes, guys. Even the fibrosis and the inflammation, formation of granulation tissue chronically with gastritis or an ulcer can cause the stenosis. That can be a complication of the gastritis and a peptic ulcer that can lead to an obstruction of the pylorus that can cause acquired pyloric stenosis, maybe because of a malignancy or a chronic itis condition, right? So the nerve muscle thing, what you have to remember about the stomach is another one is the gastroparesis. The gastroparesis is nothing but the dysmotility of the stomach because of impaired nerve condition in things like post-vagotomy or autoimmune diabetes, right? So coming to the next thing, we're talking about the normal physiological mechanism. See, if somebody throws some acid on your face, like, you know, it gets burned, but still our stomach producing so much acid, so much of digestive factors, it is able to tolerate all the acid. So there should be something which is protecting the stomach from the acid it is producing, right? So what are the protective factors and what can lead to the depletion of this? We'll know, right? So there is an equilibrium between the protective factors and the acid production always. So what is the acid production by the parietal cells, if you remember? So what is the protective factors? The surface mucus secretion. I told you the fundus and the pylorus also have the mucus secreting cells. So that will protect the bicarbonate secretion into the mucus. So this will create an alkaline tide. So whenever there is the H plus ion release, then there is a bicarbonate release to have an alkaline type. The mucosal blood flow. See, for something to get secreted, the blood flow is very, very important. So the stomach mucosal epithelial blood flow is one thing which is protecting. So anything which is depleting it, like you're not drinking water, there is no proper blood flow, you're anemic, there is no proper blood flow, even that will increase acidity, right? Then epithelial barrier function, then epithelial regenerative capacity. See, the epithelial regenerative, any epithelium of the body gets rejuvenated. I told you in the last class about the skin which can get dried, then, you know, it will just rejuvenate if you can see. So it's the same thing, elaboration of the prostaglandins. Prostaglandins are important to protect the mucosa from the acid secretion. So whenever there is an imbalance between the prostaglandin secretion, or there is something that is inhibiting the prostaglandin secretion, that is the inflammatory drugs we talk about, so like aspirin or something, that will inhibit the prostaglandin secretion, and then that will cause an injury. So there can be these damaging factors like gastric acidity, and the peptic enzymes are tolerated by all these protective factors. So whenever there is this protective factors, we're trying to help the mucosa to remain in an equilibrium. That's a physiological equilibrium. So if this gets disturbed by a H. pylori infection, or aspirin-like drugs, or tobacco, alcohol, gastric hyperacidity, duodenal gastric reflux, all these things can cause injury. I already told you the mucosal blood flow is important. If there is ischemia or shock, that is hypovolemia or a septic shock, the defenses are impaired, that will lead to eventually an ulcer. So initially there is hyperacidity, then there is ulcer formation, because absolutely the same thing what happens to our face when the acid comes, the same thing happens there. So there is an ulcer formation. How do you define an ulcer? See, the erosion is something which is just a breach in the epithelial layer. The ulcer is something where is there is the erosion or the denuded epithelium along with the mucosa and submucosa, or even deep. That is the ulcer formation. So there is disruption of all these layers of mucosa, submucosa, and the muscularis. So how you look about the ulcer is that you can find the necrotic debris, because scar, pour an acid, what happens then? Non-specific acute inflammation. So the number of neutrophils. Neutrophils are the cells which are a sign of acute inflammation, and the chronic inflammation is lymphocytes, remember. Then there is formation of granulation tissue, and then there is fibrosis. So I scratch my skin, or maybe I injure my skin. What happens? There is an acute inflammation, the neutrophils come, and then there is some the skin wants to heal itself. So because of that, what happens? There is a granulation tissue. The fibroblasts, they proliferate, then they form the fibrosis, which eventually tries to heal it. So even the ulcer formation, it will try to heal the ulcer itself by all these things, right? So this is an ulcer, you can see. So what are the inflammatory lesions? The inflammatory lesions is itis, the same thing like esophagitis, gastritis, right? So the gastritis is abdominal discomfort or dyspepsia in the absence of clinical signs and radiological abnormalities. Okay, well, how can you divide acute or chronic? Acute gastritis is again classified into acute H. pylori gastritis, that is Helicobacter pylori gastritis, other acute infective gastritis caused by everything else other than the Helicobacter pylori, and then acute non-infective gastritis, right? So these are the three things you have to remember. Then coming to the chronic gastritis, type A is autoimmune. So when I say it is autoimmune, we are trying to kill our own cells, right? You're recognizing your own cell, which is helping you as a foreign antigen, and then you're trying to have an antibody towards it. So this is about the autoimmune type. So this is usually the body and the funding predominant. So it's 4 parts. We have 2 parts here which are predominant. Then the type B, that is Helicobacter pylori related. This is antral predominant. Antral is the 4th part, right? So coming to the type AB, that's mixed environmental antral body gastritis. So then chemical gastritis, that is antral body predominant, and miscellaneous form. Just remember this, acute and chronic. In the acute, we have infectious other than the Helicobacter pylori, then Helicobacter pylori, and then non-infective gastritis, right? Then chronic, you remember A, B, and AB, right? It's like blood groups, A, B, and AB. So A is autoimmune, B is H. pylori related, type AB is mixed environment. So what is etiopathogenesis? The same thing, I eat kurkure every day, I eat lot of masala food, then I definitely will have some sort of gastritis. So highly spiced food, excessive alcohol, then heavy smoking, malnutrition, right? Infections, the Helicobacter pylori, also the viral infections. Then the drugs, I told you what aspirin does, it will inhibit the prostaglandin release, so elaborating the production of the acid and the damage caused by it. So the chemical and the physical agents like caustic soda, phenol, and Lysol, severe stress. See, there is always a neural and the muscular coordination and the neural and the cell coordination. So if your endocrine system is imbalanced, then there definitely be a lot of hormonal disturbances, and one of it will be the gastritis. So extensive burns. See, the burns will cause curling ulcers. It's called curling, curl, right? Hair curl. And there is something called as Cushing's ulcer. Cushing's ulcer is nothing but it is because of an ulcer formed because of a CNS injury, because of loss of the nerve coordination. Then surgeries. So what happens here? Reduced blood flow, obviously increased acid secretion, H. pylori infection, decreased production of bicarbonate buffer. So what all the protective factors, they are lost. Just remember that. Any serious illness like burn, shock, any other serious illness can cause physiological alterations in the equilibrium of the stomach, and it can cause the gastritis. And the morphology, the gastric mucosa is edematous, and there can be hemorrhagic spots, then it is called as acute hemorrhagic gastritis. Then microscopically acute, you're seeing many neutrophils in lamina propria. I told you the acute hemorrhagic and erosive, the mucosa is completely sloughed off and now numerous hemorrhages are seen on the surface. So we finished about acute gastritis, what it causes, the loss of protective mechanism, any kind of surgical stress or any kind of thing which will cause stress that can lead to acute gastritis, right? So chronic gastritis, you can see usually in the biopsies of stomach affecting mainly elderly age. The etiopathogenesis is the reflux of duodenal contents of the stomach. I already told you it is about the infection with the Helicobacter pylori that can cause about acute gastritis. If it is present for many years, it can cause chronic gastritis. So it is also causing chronic hypochromic anemia, immunological factors such as autoantibodies, gastric parietal cells, and intrinsic factor. See, while talking about chronic gastritis, I talked about type A, type B, and type AB. Right? Type AB is mixed, type B is Helicobacter pylori, type A is autoimmune. So in the autoimmune, there are autoantibodies to the gastric parietal cells and the intrinsic factor released by it. So what will happen? Intrinsic factor is essential for what? So vitamin B12 mechanism, if you remember, so that may lead to pernicious anemia, and you can see it as a macrocytic picture can be visualized, and for that you can do a testing, right? So coming to the classification, type A, I told you, type B and type B, AB. Now, what is the difference between H. pylori associated, that is type B gastritis, and autoimmune? See, the location, that is antrum, and the body. Here, H. pylori, you have significant subepithelial plasma cells. This is the hallmark of the H. pylori. Okay, and the autoimmune, you can see lymphocytes and the macrophages. The acid production here is increased. The autoimmune, it is decreased. Okay, because there is autoantibodies. The gastrin secretion is normal, and here it is increased. Okay, other lesions associated with H. pylori are hyperplastic polyp formation, and in autoimmune, neuroendocrine hyperplasia. See, autoimmune is nothing but the cells which you want are recognized as a foreign, and you produce an antibody towards it. And the antibodies in the form of hormones or endocrine cells also get hyperplastic, and then that releases increased gastrin, and there can be neuroendocrine hyperplasia. So how I'll identify antibody to H. pylori can be demonstrated, and here in autoimmune, antibody to parietal cells can be demonstrated. What are the sequelae? Peptic ulcer, adenocarcinoma can be formed, and then in autoimmune there can be atrophy, pernicious anemia, carcinoid, and adenocarcinoma. So H. pylori is associated with peptic ulcer, adenocarcinoma. I didn't write here, but it is also associated with mucosa-associated lymphoid tissue, marred lymphoma. And autoimmune, here you are seeing pernicious anemia because of the antibody to the intrinsic factor, carcinoid because of hyperplastic neuroendocrine cells, and then the adenocarcinoma. So how we'll see, it's the same thing. It can be normal, atrophied, or edematous. So according to the morphology, again the chronic gastritis is subdivided on the basis of extent of inflammatory changes, that is either superficial or deep. And then the activity of inflammation, whether it is quiescent or active, acute or chronic, and presence and type of metaplasia. So three things you have to remember here: superficial or deep, extension of the inflammatory changes, activity of inflammation with the active, acute or chronic, then presence of metaplasia. On these three things, again we divide the chronic gastritis. So chronic superficial gastritis, that means it's just a mucosa which is involved. Then chronic atrophic gastritis, there is loss of the mucosa, gastric atrophy without itis, that means without inflammation. Then chronic hypertrophic gastritis, that means you can see that it is also called as Menetrier disease. There is hyperplastic thing, so this is the hypertrophic. Then uncommon forms of gastritis, also like eosinophilic and lymphocytic, which I'll tell you. So there is another classification which includes, see, according to those three, extent of inflammation, activity, and metaplasia, we are dividing them as chronic superficial atrophic, gastric atrophy, chronic hypertrophic gastritis, and uncommon forms. In the other classification, which is called a Sydney system, it includes the etiology, whether it is autoimmune or H. pylori or what, and location, whether it is body, fundus or what, and the morphology, what kind of epithelium is involved, what are the cells involved, then special features like granulomas, eosinophilic gastritis, and hemorrhage, etc. So just remember, there is some Sydney system wherein there is an extra things which are taken into consideration for the classification. So coming to the chronic superficial gastritis, you are finding plasma cells and the lymphocytes in the superficial layer. No histological changes in the deep layer. That's the reason why you're calling it as superficial gastritis. So there is H. pylori that can be associated with chronic superficial gastritis. That's a spiral shaped bacteria. Okay. So it is very, very important cause that if you just remove the H. pylori, even the lymphoma sometimes can regress. So that's about the H. pylori treatment. The organism is identified on the epithelial layer. So how do you identify it? Already told you the difference. Presence of neutrophils and subepithelial plasma cells. Now, the extra point you have to remember is the pit abscess formation. And how do you demonstrate the H. pylori? It is by using a Wharton Starner silver stain and the GMSA stain. So there is something, see, any microorganism can survive in a hostile environment because of some thing which it has. Either its structure, or if it is having an ethicin or a porin which it can get attached to, or then it can have a special enzyme which can make it resistant to the antibodies which our body produces. So to cope up with all these things, the bacteria will have certain things. So in H. pylori, there is a urease enzyme which will convert the amine group of the proteins into ammonia. So that will help us in identifying the H. pylori. So what is it? it is the urease enzyme that is converting the amine groups of the proteins into ammonia. That can be uh, identified by a non-invasive test known as urease breath test, or an invasive test like a biopsy demonstrating the urease enzyme. And the other things by which we can know is a stool antigen test. After 8 weeks of treatment with of H. pylori, if you're able to say that you're not able to see any kind of antigen in the stool, then it means that you have treated it. It doesn't mean that the disease won't recur though, right? So how it is diagnosed? By histopathological examination, demonstration of urease, culture, and the non-invasive tests like ELISA, stool antigen test, and urease breath test, right? So the H. pylori infection after months can be symptomatic, after years can cause gastritis, which can be atrophic or superficial. Then it can cause a gastric ulcer 3 to 6 more times, more prone, then gastric carcinoma with precursor like intestinal metaplasia, then it is more common. Then it can also lead to a lymphoproliferative disorder known as malt lymphoma 6 to 50 times. See, this is important. The H. pylori can activate the malt, which is normally present in the stomach and duodenum, and then it can cause a malt lymphoma, right? So you should also know that this is a spiral-shaped organism that is usually superficially present in the epithelium, and you can see chronic inflammatory cells. Here also you can find this is a H&E stain demonstrating the spiral-shaped bacteria. The GMSA stain, you can see it's like a comma. Okay, this is a spiral-shaped. And this is a Wharton-Starry stain. Wharton-Starry stain, which is really used to demonstrate the H. pylori. Okay, see here, these things are the H. pylori, the comma-shaped organisms. Okay, all these things, this one, this is the epithelium, and all these are the organism. The same thing which is seen here. Okay, there is lot of inflammation happening because of the H. pylori infection that is evident in the mucosa and here in the submucosa. So chronic atrophic gastritis, I told you, atrophy means there is loss of epithelium associated again with intestinal metaplasia with presence of mucous goblet cells. Parietal cells are few or absent. Then pseudopyloric metaplasia also can happen, wherein the appearance is in almost like we have seen the pyloric glands, right? So this is a pseudopyloric metaplasia and the intestinal metaplasia in the chronic atrophic gastritis. Okay. So here you can see this is the normal pyloric mucosa, that is a foveolar mucus secreting cells in the gastric cells. If it is replaced by the goblet cells, which are columnar cells containing the mucus, and the nucleus is pushed to one side, so these are the goblet cells. Okay, then it is called as chronic atrophic gastritis. Here you can see there is loss of the epithelium and then there is an inflammation. Okay. Now gastric atrophy, thinning of the gastric mucosa with glands, but no inflammation. That's how you have to differentiate the chronic atrophic gastritis from that of gastric atrophy, right? Then chronic hypertrophic gastritis, otherwise called as Menetrius disease, nothing but thickening of the rugal folds. Okay, how you demonstrate this microscopically? It is just that the gastric pits are elongated, then tortuous and marked thickening of the mucosa that may lead to cancer. So we spoke about chronic superficial gastritis, chronic atrophic gastritis, gastric atrophy, and then last chronic hypertrophic gastritis or the Menetrius disease. Now we are dealing about the eosinophilic gastritis, just that it is infiltrated by eosinophils. The hemorrhagic gastritis with lot of hemorrhages, the chronic follicular gastritis with many lymphoid cells, and the granulomatous gastritis, which is seen in tuberculosis, Crohn's, and the sarcoidosis. See, there can be predisposition to cancer because of an intestinal metaplasia, because gastric cancer can arise. Half of all the stomach cancers are Usually there are some types of stomach cancer, that is intestinal or diffuse. So half of stomach cancers are intestinal cell type. So when there is an intestinal metaplasia in the gastric mucosa, you have to be screening the patient. And many gastric cancers show aminopeptidase activity like that of intestinal metaplasia. So any metaplasia can lead to dysplasia, then to low grade, and then high grade carcinoma, then invasive gastric cancer. So to summarize about this gastritis, there can be acute or chronic. The acute because of various agents I told you, and the chronic because of reflux, H. pylori. And based on the gastritis, I told you extent of inflammation and the location, everything. There is Sydney classification, other classification, what I told you. Then coming to the other one, that is a peptic ulcer. The peptic ulcer, we are just going to see all these things. The peptic ulcers are the areas of degeneration and necrosis of gastrointestinal mucosa exposed to acid peptic secretion. So there is a lot of gastritis, then you get confused between gastritis and peptic ulcer usually. Here there is proper ulcer formation, and then it is because of the acid peptic secretions. Just remember that. It can be duodenal or gastric, these peptic ulcers. So here you are seeing the duodenum is more common, and then there can be stress ulcers. The psychological and physiological stress may be the cause. So I told you there are a lot of conditions. Anything which disrupts the equilibrium will cause the formation of the ulcer. So shock, severe trauma, septicemia, extensive burns. I already told you about the Kurling's ulcers. Then intracranial lesions. I told you that's called Cushing ulcer. Drug intake, local irritants. Then how it is occurring? It is because of the depletion of the gastric mucus barrier. So there is absolutely no barrier, and ischemic hypoxic injury. That means there is reduced blood flow. These are the 2 points you have to remember in the pathogenesis of a peptic ulcer. So usually there can be multiple over measuring less than 2 centimeters. In spite of that, there is something called a stress ulcer that is shallow and does not invade the muscular layer. Remember, there is something called a stress ulcer, which are shallow, they are not deep. Okay. Obviously, whenever there is an ulcer, there will be an inflammatory reaction and fibrosis, which is trying to heal the ulcer and may eventually cause a complication. So there are 2 ulcers, the duodenal ulcer more common than the gastric ulcer, and both are more common in males than the females, right? So there is a loss of protective mucosal barrier by digestion by the acid pepsin, okay? So what are the causes? NSAIDs, Helicobacter, gastritis. See, gastritis is one of the cause of the damage, okay? And dietary factors, psychological, genetic, hormonal, miscellaneous. So coming to the pathogenesis, we're seeing that it is hypersecretion of the gastric acid, wherein you can see rapid emptying of the stomach. See, whenever you have eaten spicy food, sometimes you must have felt like you have to rush to the bathroom, right? So there's rapid emptying of the stomach, broken mucosal defense, host factors, and bacterial factors. See, I told you the bacterial factors previously, the structure of the bacteria, the adhesins, the porins, and the antigens it is attached to in the human body, and the special enzymes. For example, in Helicobacter pylori, there is CAG and BACA, BAC-A. These are the antigens which it possesses, which has the defense towards the host immunity. So that's how it survives. CAG is a cytokine associated antigen, and bacylated associated antigen is the BAC. Bacylated associated cytokine is the VAC. So VAC and CAG, CAG and VAC are the 2 things which help the Helicobacter pylori to survive. The host factors, see, sometimes you're eating abnormally at abnormal times, you're not eating properly, and you're not taking care, you're alcoholic, smoking, all these things can elevate the disease. Those are the host factors. And also if there is propensity like an autoimmune disease, that will cause, and then there can be elaboration of the host factors like elaboration of the pro-inflammatory cytokines like tumor necrosis factor and interleukin 1 beta, and then decreasing of the anti-inflammatory cytokines like the IL-10. Okay. So there should be a balance between the pro-inflammatory cytokines and the anti-inflammatory cytokines. So if it has lost, those host factors also will help to cause the peptic ulcer. So this is a diagram depicting the gastric and duodenal factors. Yes, you can see increased vagal activity, parietal cell hyperplasia, increased gastric secretion, rapid gastric emptying, and H. pylori. These are the gastric factors. And then these are the duodenal factors, that is sensitive mucosa to acid injury, decreased mucosal bicarbonate secretion, decreased retrograde motility, okay, and then hyperacidification of duodenal bulb. The pancreatic secretions are unable to reach the duodenum. The somatostatin, which is released, cannot reach the duodenum. So all these things will cause the ulcer formation. And coming to the Helicobacter pylori, it can cause gastritis, increase the postprandial gastrin secretion, reduce the somatostatin. This will increase the basal gastric acid secretion, hyperacidity of duodenal bulb, duodenitis, and gastric metaplasia causing the duodenal ulcer. So there is a nitis first, there is a metaplasia, then there is a dysplasia, there can be an ulcer formation, and then it may predispose to malignancy. But duodenal ulcers are very rare to cause a malignancy. So just in brief about the morphology, it occurs along the lesser curvature. Duodenal ulcer occurs in the first part of the duodenum. The duodenal ulcers, when benign, have flat margins, and peptic ulcer grossly are usually solitary, small, round, and have punched out margin. Developing carcinoma is like very rare in both. And then the malignant gastric ulcer. See, whenever you are seeing an ulcer grossly, you have to differentiate it from the malignancy. So how you will differentiate is that the malignant ulcer will have an indurated mucosa at the ends. Okay. So the gastric ulcer will have these zones, that is necrotic zone, superficial exudative zone, which is consisting of lot of inflammatory cells, the granulation tissue zone, and then zone of cicatrization where it is fibrosed. Okay, this is the gastric ulcer. You can see the rolled out margins. This is the ulcer in the stomach. Here you can see this is the mucosa, and there is this loss of epithelium here, and the hemorrhage, and there is lot of inflammation. Here you are seeing the duodenal ulcer. See, the margins are normal, they are not indurated. Unlike here, you are seeing a bit of induration. So to differentiate between benign ulcer and malignant ulcer, we are seeing a small sized ulcer with a punched out margin. This is large sized ulcer with a rolled out margin. So indurated and rolled out margin are more commonly associated with the malignant ulcer. Punched out margin is more commonly associated with benign ulcer. So here you are seeing the zones. This is the zone, superficial exudative zone, the zone of cicatrization, necrotic zone, and the granulation tissue zone. These are the 4 zones you have to remember. Okay, this is same thing depicted here. Superficial exudative zone, ulcerated mucosa, then this is the granulation tissue zone, this is the new formed blood vessels, then zone of cicatrization. Complications, obviously there can be obstruction, acute peritonitis, because there is an ulcer, the contents of the food may go into the peritoneum and may cause peritonitis, then malignant transformation. Then coming to the clinical details, there can be pain, periodicity, vomitings, hematemesis, melena, appetite loss, diet and weight, and deep tenderness. These have to be noted. So how you differentiate duodenal ulcer and gastric ulcer? Most important thing is a patient, if he says that the pain is relieved by the food, then usually it is a duodenal ulcer. If the pain is exacerbated by taking food, that is gastric ulcer. H. pylori association, disruption of mucous barrier, hyperacidity. Here it is normal or low acidity. And complications, you are seeing the malignant transformation is less for both. Night pain is usually seen in duodenal ulcer and no night pain, whereas the gastric ulcer, vomiting and hematemesis are more common, while duodenal ulcer, melena is more common. There can be seasonal variation. and no seasonal variation with gastric ulcer. The last one we are going to talk about now is the Zollinger-Ellison syndrome. It is a malignant tumor producing the excess gastrin, causing hyperacidity with increased parietal cell mass. It can be sporadic in nature or associated with MEN1. MEN1, you know, is multiple endocrine neoplasia type 1, wherein there can be pituitary and parathyroid adenomas, and also the Zollinger-Ellison syndrome or the gastrinoma. Clinical feature, epigastric pain with weight loss. So whenever you find a patient with malignancy, there can be weight loss. Heartburn with gastroesophageal reflux disease. Acid hypersaturation with diarrhea. This is the main criteria to identify as Zollinger-Ellison syndrome. See, everybody has gastritis if you are not eating home food. So what kind of person you have to look into while you are trying to diagnose Zollinger-Ellison syndrome is something you have to know. Then lab investigations. See, for knowing there is hyperacidity, there is a test called as basal acid output test, that is called as BAO. And then you are actually trying to stimulate the acid again, and then you will see if there is how much acid output is there. That is called as maximum acid output. So there is a ratio between the basal acid output and the maximal acid output. This, if it is increased, it will cause, it is a clue for the Zollinger-Ellison syndrome. Usually the BAO by MAO, that is maximal acid output, is less than 0.2/1. Okay. Then serum gastrin levels, if measured more than 1000 picogram per ml, and secretin stimulation test can be done, and the serum gastrin level, when you do this stimulation test, more than 200 picogram per ml is one of the diagnostic factors for Zollinger-Ellison syndrome. There can be, I told you while talking about the congenital pyloric stenosis, there can be gastric outlet obstruction which is acquired, that can be seen in 10% of peptic ulcer disease patient, that can be narrowing the lumen with a muscular spasm or muscular hypertrophy causing a scar. So the take home message, the gastritis is one of the cause of formation of a peptic ulcer. It can be a gastric ulcer or a duodenal ulcer. Duodenal ulcers are more common than the gastric ulcer. Duodenal ulcer will get relieved by taking food. The night pain is more common. And then seasonal variation is present, whereas the gastric ulcer, with food, the pain gets elaborated. Then you have vomiting associated with it, no seasonal variation. Remember all these things, the causes are multifactorial, and then you can see the zones which you have to remember in the chronic peptic ulcer: 4 zones: necrotic, superficial, exudative, granulation tissue, and the zone of cicatrization. The complications are same: obstruction, hemorrhage, perforation, and very, very, very rarely there can be the malignant chain. So see you in the next class. We'll deal with stomach malignancy. I hope you'll be ready to answer a few more questions regarding the stomach and the esophagus. Please go through your textbook. The classes are not replacement of the textbook. In the lockdown period is a good period that you have to utilize it for your academic activities, right? Thank you. Thank you so much.